Okay, team. Last section here, we're going to talk about post-renal AKIs. This is a much shorter lecture or the much shorter section. So again, we'll talk about the pathophysiology, etiologies, patient presentations, and treatment. We'll see here that the post-renal AKIs are typically due to obstruction, and it can be anywhere from the urethra to the ureter. So this can be anywhere from the tubule to the ureter. So after the distal canalicular tubule to the ureter, that these post-renal AKIs can occur. Etiologies can be medication related, so peripheral neuropathy and urinary tract obstruction. Most commonly, prostate enlargement. You can have patients with neurogenic bladder, a neurolithiasis, or so this is a kidney stone, or a catheter obstruction that could be causing it. Most common is probably prostate enlargement and nephrolysis. So some medications that can cause urinary retention and some medication related causes, you do want to make sure that you DC these if the patient's on them and is having a post-renal obstruction, include anticholinergics, which we know they have the you can't see, you can't pee, you can't spit, you can't as their side effects. And so this is the can't pee part. And you'll see here there's a lot of drugs listed. Also in pain management, opioids commonly cause urinary obstruction, or not urinary obstruction, but urinary retention. You also have drugs that can cause nephrocalcitosis and nephrolysis. These are agents that cause crystallization of the medication, leading to development of stones. You can do some things drug specific to help this, such as alkalizing or acidizing your urine, but it is agent specific. And I did list some medications up here at the top. Please note the ones that I highlighted here as the most common. Big thing here is to maintain hydration, and that is why one of the risk factors is intravascular volume depletion. Treatment really is removing the offending agent and providing hydration. So in post-renal, the way the patient presents is typically you can see obstruction via imaging. You'll also see things like a palpable bladder, urinary urgency and hesitancy, often blood in the urine, and in their urinalysis, they'll see crystalluria. A lot of patients will even have complete anuria where they can't pee at all, but they have a feeling of enlargement. Again, these are some things we'll see on the physical exam, such as a palpable bladder, a pelvic mass, prostate enlargement, and then complete anuria. So, how do we treat it? So, first we need to remove the cause of the obstruction. So, catheterization or surgery for decompression is often used. Remove agents which promote urinary retention, so opioids and anticholinergics. Provide supportive care, so this would be hydration often. And then, if the patient specifically has benign prostate hypertrophy or BPH, you can consider giving an alpha blocker like tamsulosin or 5-alpha reductase inhibitors such as finasteride. So, alpha blockers usually act quicker versus the 5-alpha reductase inhibitors act longer. You'll learn more about these in special populations in your P3 here. What you can see here is that in post-renal, once we have a positive for obstruction, hyponephrosis, or we have any of those physical exam findings, such as a palpable mass or bladder, we know that it's a post-renal AKI. We can stop all drug-related causes and relieve obstruction and catheterization. It's also notable that the phenos on these will be also greater than 2%.